Ventricular septal defect, introduction and background. VSD is mostly diagnosed and, when indicated, treated before adulthood. Spontaneous closure is frequent in childhood. Several locations of the defect within the interventricular septum are possible, and this can be divided into four groups according to their location within the RV. Nomenclature varies and synonyms are added. Perimembranous, paramembranous, subaortic, conoventricular, most common 80% of VSDs located in the membranous septum with possible extension into inlet, travicular or outlet septum, adjacent to tricuspid and aortic valve, so-called aneurysms of the membranous septum, that is tissue from the septal leaflet of the tricuspid valve, are frequent and may result in partial or complete closure. Muscular or travicular, up to 15 to 20%, completely surrounded by muscle. Various locations, frequently multiple. Spontaneous closure, particularly frequent. Outlet, with or without malalignment of the outlet septum. Supracrystal, subarterial, subpulmonary, infundibular, conal, doubly committed juxta-arterial. 5% located beneath the semilunar valves in the conal or outlet septum may be associated with progressive aortic regurgitation due to prolapse of the right aortic cusp and aneurysms of the sinus of Valsalva. Inlet, AV canal, AVSD type, inlet of the ventricular septum immediately inferior to the AV valve apparatus, associated with a common AV valve, may be associated with AV septal malalignment and straddling tricuspid valve, typically occurring in Down syndrome. Often there is one single defect, but multiple defects do occur. VSD is also a common component of complex anomalies such as tetralogy of Fallot, transposition of the great arteries (TGA), and congenitally corrected TGA. Spontaneous closure occurs mainly during childhood and is uncommon in outlet defects. The direction and magnitude of the shunt are determined by pulmonary vascular resistance and systemic vascular resistance, the size of the defect, LV, RV, systolic and diastolic function, and the presence of right ventricular outflow tract obstruction and left ventricular outflow tract obstruction. Clinical presentation and natural history. The usual clinical presentation in adults include VSD operated on in childhood without residual VSD and no pulmonary hypertension. VSD operated on in childhood with residual VSD. The residual shunt size determines the degree of LV volume overload and the development of pulmonary hypertension. Small VSD with insignificant left to right shunt without LV volume overload or pulmonary hypertension. Restrictive VSD which was not considered for surgery in childhood. VSD with left to right shunt, pulmonary hypertension, various degrees and various degrees of LV volume overload, rare. VSD with right to left shunt, Eisenmenger syndrome. Large non-restrictive VSD with originally large left to right shunt and development of severe pulmonary vascular disease, eventually resulting in shunt reversal. A large majority of patients with a VSD that has been closed entirely in childhood, spontaneously or surgically, or patients with a small VSD who were either never operated on or who had a residual defect after surgical repair with no LV volume overload on echocardiography usually remain asymptomatic and do not require further surgery. However, an unknown percentage of patients with a small residual VSD develop problems later in life. Survival 40 years after closure appears to remain slightly lower than in the general population. Now, several possible problems may occur with advancing age. A double chambered RV can develop over time. mostly in perimembranous defects, and may be a result of the jet lesion of the RV endothelium caused by the high velocity VSD jet. In the case of an outlet supracrystal VSD, less commonly perimembranous, there is a risk for prolapse of the right coronary or non-coronary cusp of the aortic valve, resulting in progressive AR and formation of a sinus of Valsalva aneurysm. Arrhythmia can occur but are less frequent than in other forms of congenital heart disease. Complete heart block, rare nowadays, was not uncommon in the earlier years of cardiac surgery, so can occur especially in older patients. These patients usually require lifelong pacing, late LV dysfunction and heart failure, endocarditis. Now, diagnostic workup. Specific clinical findings include a holosystolic murmur over the third or fourth left intercostal space and a precordial thrill may be felt. Echocardiography is the key diagnostic technique in general, providing the diagnosis and assessment of disease severity. Key findings to provide are location, number and size of defects, severity of LV volume overload, and estimated pulmonary arterial pressure. AR due to prolapse of the right or non-coronary cusp must be checked for, especially in the case of outlet, that is supracrystal and high perimembranous VSDs. DCRV and sinus of Valsalva aneurysm must be excluded. CMR can serve as an alternative if echocardiography is insufficient, particularly for assessment of LV volume overload and shunt quantification. Cardiac catheterization is required in case of non-invasive signs of pulmonary arterial pressure elevation. Calculated systolic pulmonary arterial pressure more than 40 mm mercury or indirect signs when pulmonary arterial pressure cannot be estimated to determine pulmonary vascular resistance. Exercise testing should be performed in patients with pulmonary arterial hypertension to exclude desaturation. Now, surgical or catheter interventional treatment. Indications for intervention are summarized in the recommendations for intervention in ventricular septal defect, native and residual. Surgical closure can be performed with low operative mortality 1 to 2% and good long-term results. Transcatheter closure has become an alternative, particularly in residual VSDs, in VSDs that are poorly accessible for surgical closure, and in muscular VSDs that are located centrally in the interventricular septum. In perimembranous VSD, it has been shown to be feasible, whether the risk of complete AV block and entrapment of tricuspid valve tissue leading to TR or the risk of AR that has been observed in children is relevant in adults undergoing interventional closure of a perimembranous VSD remains to be seen. Patients eligible for VSD closure at adult age are rare. Most patients have either small VSDs with insignificant shunt or have already developed pulmonary hypertension. The latter must be evaluated with particular caution. Patients with shunt closure and persistent or progressive pulmonary arterial hypertension appear to have a particularly poor outcome. Now, recommendations for intervention in ventricular septal defect, native and residual. In patients with evidence of LV volume overload and no pulmonary arterial hypertension, no non-invasive signs of pulmonary arterial pressure elevation or invasive confirmation of PVR less than 3 Wood unit. In case of such signs, VSD closure is recommended regardless of symptoms. Class 1 indication. In patients with no significant left to right shunt but a history of repeated episodes of infective endocarditis, VSD closure should be considered. Class 2A indication. In patients with VSD associated prolapse of an aortic valve cusp causing progressive AR, surgery should be considered. Class 2A indication. In patients who have developed pulmonary arterial hypertension with PVR 3 to 5 wood unit, VSD closure should be considered when there is still significant left to right shunt, that is QP/QS ratio is more than 1.5. It is class 2A indication. In patients who have developed pulmonary arterial hypertension with PVR more than or equal to 5 wood unit, VSD closure may be considered when there is still significant left to right shunt, QP/QS ratio more than 1.5, but careful individual decision in expert centers is required. Class 2B indication. VSD closure is not recommended in patients with Eisenmenger physiology and patients with severe pulmonary arterial hypertension, PVR more than or equal to 5 wood unit, presenting with desaturation on exercise. Class 3 indication. Now follow-up recommendations. Development of AR or TR, degree of residual shunt, LV dysfunction, elevation of pulmonary arterial pressure, or development of DCRV should be excluded or assessed if present by echocardiography. Possible development of complete AV block requires attention. Patients who develop bifascicular block or transient trifascicular block after VSD closure are at risk in later years for the development of complete AV block. Patients with more than small residual VSD, valvular lesions or hemodynamic impairment, LV dysfunction or pulmonary arterial hypertension should be seen every year, including evaluation in specialized adult congenital heart disease centers. In patients with a small VSD, native or residual, normal LV, normal pulmonary arterial pressure, asymptomatic, and no other lesion, 3 to 5 year intervals may be reasonable. After device closure, regular follow-up during the first 2 years and then, depending on the results, every 2 to 5 years is reasonable. After surgical closure without residual abnormality, 5-year intervals may be reasonable. Additional considerations: exercise or sports. No restrictions are required in patients after VSD closure or with small VSD without pulmonary hypertension, significant arrhythmias or LV dysfunction. Patients with pulmonary arterial hypertension must limit themselves to low intensity recreational activity or sports. Pregnancy. Patients with precapillary pulmonary hypertension should be counseled against pregnancy. The risk is low in asymptomatic patients with normal LV and no pulmonary arterial hypertension. Infective endocarditis prophylaxis recommended only for high risk patients. Now the diagram shows, the flowchart shows management of ventricular septal defect. First, we consider if there is presence of LV volume overload. If there is no LV volume overload, then we see about the VSD associated prolapse of an aortic valve cusp causing progressive AR. If yes, then closure is class 2A indication. If no, there is no progressive AR, then we should take about the history of repeated episodes of infective endocarditis. If he or she has repeated episodes of infective endocarditis, then closure is class 2A indication. If there is no repeated episodes of infective endocarditis, no closure. Now, if the patient has LV volume overload, then we should look for pulmonary arterial hypertension. Is it PVR? Is it more than or equal to 3 wood unit? If no, PVR is less than 3 wood unit, then closure is class 1 indication. If PVR is more than or equal to 3 wood unit, then we should look about the QP/QS ratio. If PVR is less than 5 wood unit and QP/QS ratio is more than 1.5, then closure is class 2A indication. If no, and QPQ, then QPQS ratio if more than 1.5, then closure is class 2B indication. If PVR is more than 5 wood unit and QPQS ratio is less than 1.5, then no closure, that is class 3 indication. This is the management of ventricular septal defect. Thank you.